Welcome, ladies and gentlemen. My name is Rebecca O'Brien and I am a psychology and sociology undergraduate here in the University of Limerick. I'm here to talk to you today about a disorder that affects as many as 12 in every 1,000 people, from young children to adults regardless of gender or social or cultural factors. You might be wondering what disorder I'm talking about, and it's obsessive compulsive disorder, or OCD for short. It can be so debilitating and disabling that the World Health Organization has ranked it in the top 10 of the most disabling illnesses of any kind in terms of lost earnings and diminished quality of life, and is the fourth most common psychiatric disorder. In the United States, about 1 in 40 adults are clinically recognized as having OCD, and about 1 in 100 children. OCD is characterized by persistent and uncontrollable thoughts or urges, and by the need to repeat certain acts again and again. Individuals with OCD usually try to actively dismiss or neutralize an obsession by performing a compulsion, but this is just a short-term fix that ends up feeding the OCD cycle. Both obsessions and compulsions interfere considerably with daily functioning and quality of life. Obsessions, which are also known as intrusive thoughts, are unwanted and unacceptable thoughts that seem to appear in your mind in an unbidden way, and compulsions are the physical or mental actions and reactions that follow from intrusive thoughts or obsessions. We said earlier that the occurrence of OCD in gender is equal, but the context of these obsessions and compulsions are not. More women have compulsive washing, which is the most common clinically presented manifestation, and more men have sexual obsessions, magical numbers, or obsessional slowness. Other manifestations of OCD occur with checking and verifying things and compulsive hoarding. The DSM is the Diagnostic and Statistical Manual of Mental Disorders, and its criteria for OCD is as follows. A. The presence of obsessions, compulsions, or both. B. That these are time-consuming, that they take more than 1 hour a day. C. That the disturbance is not better explained by the symptoms of any other mental disorder. And D. It is not attributable to the physiological effects of a substance, so drug abuse or medication. Any psychology or medical students in the room, you might find yourself identifying family, friends, or even yourselves in these slides. But a personality disorder such as OCD is defined by the extreme, inflexible, and maladaptive ways in which these traits are expressed. There is no single proven cause of OCD. Research suggests that OCD involves problems in communication between the front part of the brain and deeper structures. A genetic predisposition to OCD is likely, and developmental factors may include emotional, physical, and sexual abuse. OCD can present in adults as a consequence of certain neurological conditions such as a brain tumor or Huntington's chorea. So what about avenues of treatment? Firstly, you have cognitive behavioural therapy or CBT, medication, and neurosurgical treatment. Research shows that people can spend 10 years or more struggling with OCD before they get the appropriate help. The role of shame and stigma is common to many mental health problems, but can be particularly problematic for people with OCD who have ego-dystonic, sexual, or violent thoughts. CBT is a treatment that is recommended by nationally recognized institutions such as the Mayo Clinic and the Harvard Medical School. CBT, which includes exposure and response prevention, should be offered as a first-line therapy for children, young people, and adults with mild to moderate OCD. It is based on a program of structured self-help and began in the late 1960s. The first aspect of ERP, exposure, involves prolonged exposure, whereby they confront anxiety-provoking or otherwise distressing situations, and this is graded on a scale of 0 to 100. For someone with a fear of contamination, a score of 30 might be for touching the rim of an unwashed coffee cup, and a score of 100 might be for using a public toilet. The second aspect of ERP, response prevention, involves the prevention of compulsive responses or rituals that aim to neutralize the distress or threat. 75% of those treated with ERP improve significantly and stay so for up to 5 years after treatment is discontinued. Although many patients with OCD respond well to medications and psychotherapy, 40 to 60% continue to experience symptoms despite treatment. The American Association of Neurological Surgeons, as of September 2014, endorsed the use of deep brain stimulation in severe OCD patients who fail to respond to other avenues of treatment. Deep brain stimulation is the placement of electrodes in specific areas of the brain followed by electrical stimulation of these areas. Only 20% of OCD patients who don't respond to treatment experience remission, so DBS allows these people with another yet severely invasive avenue of treatment. That is the other implication of this new research, is the severity of side effects, which include infection, hemorrhage, seizures, and psychological complications. Thank you for listening.
created using Powtoon.